right. We're unmuted. Good. Yes, as Josh said, I'm Kathleen Smith. I go by Katie. And I will be talking to you today about Complex Outlier Case Review Committee, which is a committee that we have formed at NorthShore to address inpatient medical necessity denials. Next slide. So this speaks revenue integrity, right? This is what we just heard Pat talk about. Better care through denial prevention and process improvement. So I'll pause here and just talk a little bit about me. As Josh said, I'm very, very passionate. I got into the healthcare space about 12 years ago. I thought I wanted to be in the clinical space because I have this inherent need to want to help people all the time. And who needs help more than patients that are dealing with illness or really any type of thing to be in a hospital? It's just never fun, no matter what the circumstances are. I went for a blood draw with my son and nearly passed out. I was like, blood's not for me, I'm never gonna be a nurse. But I thought, how else can I assist? And working through denial management is one of those ways. Ultimately, yes, it's for reimbursement, it's to make our numbers look good, it's to reduce our AR. But also, I take great pride in the fact that that patient is no longer going to get an EOB that's telling them that they may be responsible for all of these charges. Next slide. So through NorthShore, we understand that there is significant denial impact. So when we want to we wanted to slice and dice our data to understand where should we focus. And we decided that we were going to focus on inpatient denials related to medical necessity and pre-certification, or what we call preventable denials. So through today, I'm going to go over denials. We understand how they impact patient care, not only financially to every organization, but as I mentioned previously, to the patients themselves. I'm going to talk about how we use data to drive these outcomes, to help us understand the story that we're telling, how we utilize that data to talk with and communicate with our steering committee teams, but also to drive change. I'll review with you how we structured a denials engagement committee, which is encompassed of myself and some physician advisors and analysts to obtain and keep evaluating the data. And also talk about how we developed what we call OCCRC, which is that Outlier Complex Case Review Committee. Sounds really confusing, but more to come on that. And then I also want to talk about how we've been able to establish an effective post-denials appeal process with the help of Parathon. And hopefully I can help summarize some of these steps so that you can implement some of these things in your organization to be better, more successful for your patients and also for your AR. Next slide. So before I dive into the data piece, this is a little bit of background as to how we decided what were we going to look at, which is what can we determine is preventable versus what's not preventable, and how do we target our focus areas just really looking at preventable. So denials can occur at any time. It can be pre-service. You can receive a concurrent review denial while the patient is still in-house. That happens before billing. And you can also receive denials for a variety of avoidable reasons: medical necessity, pre-certification, coding, delay in care, maybe it's an inpatient-only procedure, perhaps there's a registration error with late notification, maybe there's a level of care downgrade, Pat talked a little bit about that, or even timely filing, not getting things billed in a timely fashion. We consider unavoidable denials, things like credentialing, experimental, non-covered. Sometimes with non-covered services, you could lean towards that medical necessity era, and it could be covered, so that's kind of a gray area there. But anything that might be provider liable. So we segmented out what we thought were preventable areas that we wanted to focus on versus unpreventable areas. And from there, we developed a denial data scorecard. Next slide, please. So the denial data scorecard was no easy feat. It took months and months and months to build. Those of you that know me know that I love my data. I think data tells the story, not only for what you need to work on, but also how are you going to show your successes if you don't have accurate data? So through this denial data scorecard, which focuses on inpatient-only denials, we look at inpatient versus observation in newborn cases, reasons for the denial with specific remit codes. This is ANSI code driven. Again, kind of aligning with those categories that I mentioned on the previous slide. We break down this denial data to look at payer, specialty, length of service, and even the attending physician. Are there, and this kind of ties in what Pat was talking about too with documentation, and we review that as well. Also, looking at secondary review, our peer-to-peer opportunities, and our formal appeals writing process. This is captured in a denial snapshot. So we look at data monthly, quarterly, and also within a rolling 12-month for the preventable denial metric. So we look at, I know that sounds confusing, we look at all of our total inpatient denials and where that sits on our revenue and what that percentage looks like to our targeted preventable denials. And I have some examples of what that looks like on some next coming slides. Next slide, please. So one way that we also look at the data is to understand payer denial trends. As many of you know, there are a variety of reasons that payers deny. Some are appropriate. In my opinion, they're all inappropriate, but for purposes of this, sometimes the denial is appropriate, sometimes it is not. One of the ways that we look at this, so I've desensitized these payers, but as you can see, we utilize this to understand in January, there was this huge spike through March, and we needed to understand why. Why would our inpatient denials for this particular payer that's identified as yellow be so high? So we take that data, we dive deeper into those accounts, and we found that in this particular example, the payer was denying inappropriately. They had a system glitch and were not recognizing authorizations that had already been obtained. So this is one example of how utilizing this data and having a screenshot here will tell us and help us prioritize what areas we need to focus on. Next slide, please. We also look at denials by specialty. So on to the right, this is where we would have denied cases by number, and to the left would be denied cases by dollars. What's interesting here and why we look at it this way is because sometimes your highest denial count in numbers isn't necessarily your highest denial count in dollars. So we look at different specialties in different ways so that we can understand where should our focus areas be, what physicians do we need to talk to, how do we loop them in from the denial standpoint. Next slide, please. We also look at denial by specialty over time, or we can track the denials per specialty and quickly say, whoa, what's going on with the denial in the blue here, for example. Our data from looking at it from the different vantage points helps us to understand the different areas of improvement, as well as help us develop other hypotheses for trends that we're seeing. Next slide, and this is just one more way that we look at denials by specialty rate. So neonatal medicine is one of our highest rates for denials. A lot of times this happens with babies who are MANG pending or Medicaid pending and don't necessarily have any insurance assigned to them yet. So we work with the payers or under the mom to help make sure that the babies are covered for their stay at their time. Yes. You know what, that's a really great question, Pat. So for all of the inpatient denial data, it took months of evaluating what ANSI codes are we going to include, looking at the specialties. Are we going to go by admit date versus discharge date? Because our AR numbers are different. So my accounting team will look at days in AR by admit date, whereas me on the rev cycle side, I'm going to look at AR by discharge date. And sometimes even when I receive that payer remit to let me know when does my clock start ticking for reimbursement purposes. And we decided that we were going to go by admit date, which does skew some of the data, and sometimes we have to have a 3-month lag. So a lot of this data is pulled at a 3-month lag to allow that time for billing and for us to receive a payer denial. But also through creating this denial scorecard, we spent a lot of time looking at, do we utilize just 835 data? In other words, are we using just the first payment, or are we going to use, if there's a take-back, are we going to look at that data? Are we going to utilize manually enter denials? So for instance, my correspondence team receives a letter from Blue Cross or whomever, they're not going to pay for it, it's not covered service, and they enter that manually. So there was a lot of evaluation to create this denial scorecard. I mean, we still evaluate and look at the data monthly when it comes out to ensure that it's accurate and that we're excluding things we want to exclude and that we're telling the appropriate story. Next slide. So foundation for, my notes are out of order, sorry. So foundation for improvement. Again, like I stated before, the most important thing to me is the data. If you don't have the data, how are you going to be able to tell the story or convince other members of your team that there has to be improvement? The 3 C's, which we define as providing and creating an environment of collaboration, communication, and collegiality. The delivery of medical care is too complex for any one group to really drive meaningful change on their own. So we've brought members of different departments together to collaborate on these projects so that we have a multidisciplinary team working together for common goals. Through that, we've been able to develop and document workflows and expectations for not just case management, but for revenue cycle as well. We've utilized tools within HIT. Are there alerts in the system to help us when there are late notifications or if not all days are authorized? Completing more peer-to-peers. This was something, I believe our peer-to-peer rate over the past 12 months has increased by 72%. And we utilize that peer-to-peer information to know, one, did we overturn that denial while the patient was still in-house? Or are we going to let the denial go through and appeal it on the back end? We created this outlier case review committee, which is what I'll talk about next, and a denial engagement team, which is the weekly team of myself and the physician advisors, where we get together to talk about that data, the denials, the trends, what we're seeing, and how we can prevent it, whether or not we need to work with our own contracting team or with our payers. We utilize that weekly meeting for those purposes. Next slide. So the Outlier and Complex Case Review Committee is a weekly meeting that we have where one of our physician advisors will allocate 4 cases that we review per week. These cases are the most complex high-dollar cases that we currently have in the hospital at that time. The average charges of each case that we review is $270,000. Through this process, we have a variety of different team members on the phone. Registration, somebody there from case management, utilization management, social work, a physician advisor, coding, CDI, and PFS. And to give you a little bit of a snapshot of what these meetings look like, the physician advisor will present the case. We'll talk a little bit about patient history, what makes this case complicated, and why this patient needs such a long stay. From there, registration will talk about whether or not timely notification was met. If not, we'll break down the reasons as to why. From there, case management will talk about what they have done for submitting clinicals, concurrent review. Do we have days authorized? Is the stay fully authorized, partially authorized? And if not, what do we need to do to make sure that we obtain full authorization prior to that patient being discharged? From there, we have social work that talks about family engagement, discharge planning. I then speak up. Marie also will speak up in regards to PFS. So we educate the physicians on certain payers. So let's say the patient's going to be discharged tomorrow, but we don't have full authorization. We will educate them to say This payer, per their contract, allows us 48 hours. So if we don't secure that authorization within 48 hours, we will get a pre-cert denial, and this payer may or may not allow us to do a retro appeal post-billing for recovery. So it helps our physicians truly understand the technicalities that we face on the revenue cycle side when steps like this are missed. So far, we've reviewed 218 cases. We identified that 28% of those, 62, were opportunities that were identified through this meeting were because of the opportunity and what was identified. We were later able to successfully obtain payment and avoid getting a denial. And on the inpatient side of things, this is really significant for us because it causes us to have better AR, expedited cash. But there's continuing ongoing improvement. We want to ensure that the system stays on track. We want to make sure that we're fostering a collaborative effort between all teams. And we want to make sure that we're rotating both the nurses and social work so that they are also exposed to this meeting and the benefits of having every different department on that call to understand their specific impact for denial prevention. Next slide, please. As I mentioned previously, we have a denial engagement team and an oversight committee, which is myself, Marie, our data analysts, and our physician advisors. We meet weekly to go over the data, to discuss anything that we learned from the previous week or month. We will discuss specific cases related to that OCCRC meeting, as well as identify new opportunities. Is there a new payer trend that we're seeing? Is there a new payer policy that's come out that's going to impact the way that we help our patients and the way that we fight denials? From there, we can help plan and figure out what we need to do for both pre and post billing denials. Next slide, please. So to give you a little bit of background about post-billing denials, all of our appeals were previously written by case management. For those in RevCycle, we fully understand that case management and writing an appeal on the clinical side is a little bit of a different skill set, right? So the appeals really are, I consider them more like persuasive essays, where you have to persuade the payer with the clinical documentation as to why this service is medically necessary and should be paid for. When case management was doing this previously, they had a lot of time restraints. They were taking care of patients, and they were required to write appeals, which they had never done before. And it was causing us some time delays. We were missing appeal timelines, and we were unable to overturn those. Our success rate at that time was less than 10%. I actually want to say we went to 10%, but I think our overturn rate was more like in the 4 to 6%. We also had this challenge of manually tracking all of the appeals and the appeals success. We had to constantly, case management would notify PFS, PFS would send the appeal, PFS would follow up on it, but because there was no systematic way for us to do it within our EMR, we were having to manually review and manually track these, which made our understanding our overturn rates very challenging. So this is where Parathon comes in. As I mentioned before, writing an appeal letter for medical necessity or flipping a lack of authorization denial into a medical necessity appeal takes a lot of skill set. We outsourced this function to Parathon a little over a year ago, and we've seen significant improvement on all the aspects that I noted before. So Parathon has dedicated staff and time with the skill sets to write these appeal letters. They are very successful. We have a quicker turnaround time. We're not manually tracking anymore. Terry loves me because I'm constantly talking with her about data and how we improve it and how we look at those. But also our overturn rate is now 54%, and that's looking at last month. We've had success rates some months in the 60 to almost 70% range with inpatient medical necessity post-billing appeals. So Parathon has been great for us in that aspect, and I'm very, very grateful to the team here and all the help and assistance that they provide me. Next slide. Oh, look, you beat me to it. So, in summary, establishing the data and how we utilize the data and having a denial scorecard, as well as developing a denial engagement committee and having this outlier complex case review committee, and also implementing a successful post-billing appeals through our vendor, we've been able to reduce our denials, our inpatient denials in a 12-month period by 9.2%. So if you put that into dollars, it's fairly significant. It's also allowed us to broaden communication with different departments. We now have a better communication with contracting. And our physician advisors come to some of our payer meetings to talk about their frustration with payer technical denials when a patient is still in-house. And we've been able to work through those challenges. So early drivers to this success is making sure that we have a good peer-to-peer process put in place. So volume, making sure it's focused, making sure we have collaboration, reviewing cases weekly, repeating, utilizing our HIT. So if there's some sort of system enhancement that we can make to help, one, easily identify, or two, track, that we take full advantage of that. And then also, I can't speak enough about how important it is to have that intradepartmental communication. Prior to us establishing this, there was a lot of silos and a lot of revenue cycle feeling frustrated by the amount of denials that were coming through that were related to registration or case management or documentation. And this process has really helped me to understand the challenges that they face from the insurance level, not being able to get the contacts that they need. They're submitting clinicals, but we get no response. But also for them to help understand that there are contractual obligations that we have, and they can do all the right things at all the wrong times, and we still may not get paid. So I can't stress that enough.
Katie, quick question.
Yes.
How do you decide which cases other than the outlier triggers to include in that weekly meeting?
Sure. So like Medicare is one that we exclude. So we focus on most of our managed care contracts where they have stipulating, where our contracts are very driven towards some of those technical things that they require, concurrent review, clinicals. So Moshe, who helped me create this presentation and who is a physician advisor that I work closely with, he does that evaluation and sends out those cases that we're going to be reviewing weekly.
So it's physician driven.
It is physician driven, which goes back to your point earlier about involving clinical staff and physicians is very important to tying in revenue cycle and the impact that it has. And again, I can't stress enough my last point, because I couldn't close out without stressing again that data is extremely important and drives change.